So we know that all patients with endometrial cancer should undergo basic molecular classification that includes assessment of mismatch repair status. To date, this is the only molecular marker that really helps guide treatment decisions and helps us practically understand responsiveness to systemic therapy. So this patient has mismatch repair deficient advanced endometrial cancer and needs adjuvant systemic therapy. Her oncologist has chosen to treat her with pembrolizumab plus platinum-based chemotherapy based on results from recent studies, Ruby and GY18. So these two studies are very exciting in that they will inform and change standard of care practice and move immunotherapy into the frontline setting for women with advanced endometrial cancer. So let's talk about them a little bit. So Ruby and GY18 tested dostarlimab and pembrolizumab respectively in combination with chemotherapy in patients with advanced or recurrent endometrial cancer. Both studies looked at the role of chemotherapy with carboplatin and paclitaxel with or without the addition of immunotherapy followed by maintenance. Ruby evaluated dostarlimab while GY18 evaluated pembrolizumab. In each study, patients were required to have advanced disease, either stage 3 or stage 4 or recurrent disease. Both studies actually included not only endometrioid histology, but also high risk, less common histologies like carcinosarcoma, serous, and clear cell carcinoma. Excitingly, each study showed a statistically significant and clinically meaningful benefit in the pre-specified mismatch repair patient subgroup, as well as in the overall population. And what's important about this is that this study showed a clinically relevant benefit in progression-free survival, also in patients who were mismatch repair proficient. In terms of the comparative profiles, the drugs dostarlimab and pembrolizumab are fairly similar in terms of efficacy, tolerability, and risk for immune-related adverse events. So use of one over the other is really up to the prescribing oncologist, and most likely choice is going to be influenced by institutional formulary, provider preference and comfortability, and patient insurance approval. Patients, like I mentioned before, with endometrioid histologies were included in these studies. So I would approach a patient with a carcinosarcoma similarly to the patient presented. If this patient had proficient mismatch repair, I would also likely treat similarly based on the results from Ruby and GY18 that showed that even patients with proficient mismatch repair had clinically relevant PFS benefit. If this patient had previously received adjuvant chemotherapy, her treatment would likely be most directly informed by data from two trials, Garnet and Keynote 158. These were large basket trials investigating the use of IO monotherapy, dostarlimab and pembrolizumab respectively, in the treatment of advanced solid tumors. And each of these trials had endometrial cancer cohorts that were further delineated by mismatch repair status. And the results from these trials ultimately led to the FDA approval of these drugs as monotherapy for advanced recurrent endometrial cancers that are mismatch repair deficient. I think one of the areas in which we're not clear, because we are in this changing landscape, is what if this patient had previously received adjuvant chemotherapy, but it had been some time, let's say a number of years? Would it be appropriate to treat again with chemotherapy and immunotherapy? I don't think we have the answer to that yet, and I'm sure future studies will be done to help us clarify the sequencing of these agents.